So good morning, everyone, and welcome to the second installment of our Implementing High Quality Primary Care webinar series. Every Tuesday this month, we are diving into a different theme of the new National Academy's report, Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. Last week, we discussed payment reform. And this morning, we will be discussing access to primary care. And I am joined by a fantastic group of committee members and panelists who I want to introduce to you in just a moment. So after the introductions, we're going to have a brief presentation on how the report covered access to primary care. And then we'll move into a discussion with our panelists before taking questions from the audience for the remainder of the seminar. A recording of this event and the slides we present will be available online after the event concludes. So I'll start with introductions. I was privileged to serve to be the co-chair of this committee. I'm Linda McCauley, and I'm the Dean of Nursing at Emory University. And I'm joined today with Shauna Hudson, who is Professor and Research Division Chief of Family Medicine and Community Health at Rutgers University. Jackson Griggs is here with us. Jackson is the CEO of the Heart of Texas Community Health Center. And the co-chair of the committee and my dear colleague, Bob Phillips, is here. Bob is the founding executive director of the Center of Professionalism and Value in Healthcare of the American Board of Family Medicine. Our distinguished panelists with us today are Seiji Hayashi, who is the Chief Transformation Officer and Medical Director for Mary Center. Mary Center is a community health center that provides care, family literacy, and social services to nearly 60,000 individuals. Previously, he was the acting director and director of medicine for the Human Diagnostic Project, an effort to enable more accurate, affordable, and accessible care for all using machine learning technology. His national health policy experience comes from his role as the Chief Medical Officer for the Bureau of Primary Health Care at the Health Services and Research Administration, HRSA, where he oversaw the clinical quality strategy for the Federal Health Center program. Barbara Leach joins us. Barbara is a special project coordinator at the Family Support Program in the School of Social Work at the University of North Carolina. She has many roles in this position, ranging from providing training on family provider partnerships and collaboration to spearheading statewide work groups to serving on state-level committees to inform policy development specifically for families and children who have disabilities and coordinating state and federal grants. And then finally, Alan Morgan will join our panelists. He's the Chief Executive Officer for the National Rural Health Association. He has more than 30 years of experience in health policy at the state and federal level and is one of the nation's leading experts in rural health policy. So a very distinguished panel joining our committee members today to talk about the critical problem of access to primary care. So I'm going to turn the stage over to my colleague, Shauna Hudson, who is going to give you the background of the work the committee did on access to care. Shauna?
Great, thank you so much, Linda. So it's my distinct pleasure today to represent our committee and to talk with you about our process and about the report, and particularly with a focus today on patients and ensuring access. Next slide, please. So I want to begin today by just acknowledging the hard work of this phenomenal committee. We had 20 members who represented a variety of different professions and disciplines, and each member brought a unique and extraordinary and thoughtful contribution to our discussions and to the task of the study and the pieces that we did together. We were represented by a variety of different groups. And so one of the things that I think made this committee very strong is that we had representation of clinicians. We had nurses, physicians, dental professionals, pharmacists, physician's assistants, and as well a healthcare center CEO on our panel. In addition, we had other healthcare stakeholders who were part of this whole sort of policy and implementation space. So we had a director of community health worker program on our group. And as well, we had a number of social scientists, myself included. So we had an economist, anthropologists, and myself, a sociologist. So we had a very wide variety of different disciplines and groups who were represented. And I wanted to make sure that as we talk about this report and sort of how we came to the findings and the conclusions that we did, that you have an understanding of sort of who was at the table as we had these discussions. In addition to the committee members, I also want to make sure that I acknowledge the staff members from the Academy who actually worked with us timelessly across time for this particular project. And as well, I want to recognize the fellows who were fantastic and worked with us through this process. Finally, I want to also recognize with gratitude our sponsors for this particular program, which range from federal agencies, professional societies, private foundation sponsors, and whose generous support really made this report and this work possible. Next slide, please. So I want to start out by outlining what our statement of task was here for this particular project. And for us, our committee was focused on examining the current state of primary care in the United States. And our goal was to develop an implementation plan that would actually build on the recommendations of the 1996 IOM report, Primary Care, America's Health in a New Era. Our goal is to strengthen primary care services in the United States. And specifically, we were focused on underserved populations. And the goal, again, is to inform our primary care systems around the world. So we had a large statement of task, and it was very comprehensive. And in our next slide, I want to move into the definition that we ended up updating. So from the 1996 report, we felt that there were a number of areas that really needed to be revisited. And so our current definition is that high quality primary care is the provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams that are accountable for addressing the majority of our individuals' health and wellness needs across settings and through sustained relationships with patients, families, and communities. And this is something that we're going to come back to quite often in our discussion here today about access. As we revised our definition of primary care, we felt that there were modifications that really needed to reflect sort of where we are today in terms of our societal and sector shifts from 96. And so we really wanted to make sure that this new definition really focused on the importance of communities, the diversity of our settings and modalities that are used to deliver primary care, and as well that it actually captured the delivery of care through our interpersonal teams and through making sure that primary care is equitable. So those are some of the things that we were thinking about as we updated our definition. If you can move to the next slide. So our group felt that primary care should be treated as a common good. The committee believes this because of its societal value and its role in health equity, and that primary care should be accessible to everyone. The goal of our implementation plan is to elevate primary care to a common good status that it actually deserves and that this country needs. And so we really focused on primary care as having high societal value, that it requires public policy for oversight and monitoring, and that we need to really strongly advocate and have organized leadership and public awareness to make this happen. Next slide. So there were 5 major objectives that our report outlines. And today we're going to be focused on the second one, which is access. But I want to just go over very quickly what the other 4 areas are. So the first one is payment, which is pay for primary care teams to care for individuals, not doctors to deliver services. And so this particular objective is really focused around accountability and also focused around payment plans. The second one, which we're going to focus in depth today on, is ensuring that high quality primary care is available to every individual and every family and every community. And for us, this is essential to implementing high quality primary care. We really want to make sure that we build broad political support for this concept of a usual source of care. And it implies a 3-way partnership between patients and teams and payers, and then secured by the government as the nation's largest payer and protector of the vulnerable. So that's what we're going to be focused on today. Our third area is training primary care teams where individuals live and work. And here, we're really focused on primary care training as interprofessional and located within our community settings. We know that it's more effective when we develop skills that will keep people connected and healthy. And so focusing in on interprofessional training in our community settings is a core. The fourth area is designing information technology that serves our patients, families, and interprofessional care teams. And so we know that new health information technology standards are available, and we really felt that those should be prioritizing and facilitating integrated care that's person-centered and supports relationships and is responsive to the needs of our communities. And then finally, accountability, which is really our implementation plan. Implementing high quality primary care requires clear and meaningful measures of whole person care, ongoing research to do this, and leadership at the federal government level to assure federal policies and support its development. So all of these different elements are interrelated. And as you know, we have a series of webinars that are going to go in depth. So the one today is focused on access. There was one last week on payment, which if you were not able to catch that, you can actually see it on the website and pull down that webinar. And we invite you to join us for the next 3 weeks worth of sessions that will address items 3, 4, and 5. Next slide. So as we move into this next piece, I wanted to share a few statistics with the group to get us thinking as we think about access to care. So in 2019, there were 30 million individuals who did not have insurance who were not elderly. And more than 80 million individuals live in primary care health professional shortage areas across the country. Primary care is the only part of our healthcare system that results in longer lives and in more equity. And so it's with this in mind that we want to move to our discussion about access today. If you can go to the next slide. So when we talk about the second recommendation for the committee, focused on access and ensuring high quality primary care is available to every individual and every family and every community. What we started out with is an understanding that primary care is foundational to the healthcare system, and it's very critical for achieving high health equity. In chapter 4, which is focused on these issues, we review a significant amount of literature on the impact of person-centered, family-centered, and community-oriented primary care. And we also describe what our committee heard from patients and advocates and community members about what primary care means to them and how it can better serve us all. Through our review, the committee came away with a shared understanding that when individuals have access to primary care, we have healthier populations, and that brings about more equitable outcomes. And the committee took from all of these different inputs from the literature, from those that we talked to, and from the different advocacy groups that we met with as well. We took all of these things and looked at them in the context of needing to really reform how we think about implementing high quality primary care, and really shifted our notions to think about individuals and families in the context of their communities to provide whole person care. For this reason, I want to go back to this thought of the common good. The committee really is recommending that primary care be considered a common good that's available to everyone in the US, regardless of insurance status. And we're going to come to this again, but we really want to make sure that it's clear that we believe that primary care should be promoted with with responsible public policies and private sector action that's also sufficiently resourced to drive our health equity outcomes. Next slide. So I'm going to go through the actions that were suggested in underneath access in the report, and I'm going to talk about them individually, and then this is sort of the lead off for our discussion with the different panelists today. So for the first action, our committee has proposed 5 different action steps, and the first one is really focused on universal empanelment. We believe that all individuals should have the opportunity to have a usual source of primary care and to have an ongoing relationship with their primary care. And so what does this mean for payers? For payers such as Medicaid, Medicare, commercial insurers, and self-insured employers, this means that they should ask all of the covered individuals that they declare a usual source of primary care annually. And then also assign non-responding enrollees using established methods to track this information and to use it for payment and accountability measures. So we want to ask everyone to declare their usual source of primary care. And for those who aren't responding, then we want to actually use established methods to make sure that we're tracking this information. For the uninsured, in the settings where they seek care, which are our health centers, our hospitals, and our primary care practices. For those individuals, we're saying that they should assume and document an ongoing clinical relationship with the people that they are treating. In terms of action 2, this is really focused around supporting the underserved. And here our report recommends 2 things. The first is that HHS, enabled by congressional appropriations, should target sustained investment in the creation of new health centers in federally designated shortage areas. And this would look like and include federally qualified healthcare centers and lookalikes, school-based health centers, rural health clinics, and as well Indian Health Service facilities. Next slide. For our third action, we're really focused on improving access. And here we're focusing in on Medicaid beneficiaries and recommending that CMS revise and enforce its fee-for-service and managed care access standards for primary care, ensuring adequate access. We're also suggesting that they provide technical assistance resources to state Medicaid agencies for implementing and attaining these standards, as well as measure and publish how different states perform. The fourth action is really focused around supporting equity by permanently supporting the COVID-era rule revisions and Medicaid and Medicare benefits interpretations that have facilitated integrated team-based care. We know that these revisions have enabled more equitable access to telephone and virtual visits, that they've provided equitable payment for non-in-person visits, and that they've eased documentation requirements, expanded the role of interpersonal care team members as well. And then the final and fifth action in this grouping of actions is really proposing what I call community co-creation and partnership building. So primary care practices should really move towards a community-oriented model of primary care by including community members who have lived experiences in their governance, in our practice design, and as well in our practice delivery. We want to partner with community-based organizations. And to do this, we want to make sure, importantly, that our accrediting bodies encourage this and revise their standards so that they've helped to facilitate these changes. Next slide. So in summary, I just want to go back over some of the key pieces that we want to take away from this today. Currently, our uninsured and our insured alike fall between the cracks in this fragmented system. And what we'd like to do with this report is to really move towards more community-centered primary care models that really involve our community members in governance, in our practice design, and in our delivery, and really partner with community-based organizations in the settings in which our primary care practices are based. In addition, we want to make sure that we expand primary care in shortage areas and that we ask all covered individuals to declare a usual source of care and assume an ongoing relationship with the uninsured who are being treated. So these are sort of the high points of our report. And with this, I'm going to turn over to Linda for this next phase of our grouping for discussion. Thank you.
Thank you, Dr. Hudson, for a great summary of the committee deliberations around access to care, such an important component and a lot of passion in the committee about the need for reform in this area. And before we engage the panel, I want to ask Jackson Griggs and Bob Phillips to share some of their thoughts about this work and how it lines up with what they're currently doing and other recommendations in the report. So Jackson, I think you were going to talk a little bit about your work.
Yeah, thank you, Linda, and masterful synopsis, Shauna. Thank you so much for doing that for the group. Well, what an honor to join you today. Thanks for the opportunity. So Jackson Griggs, the CEO of Heart of Texas Community Health Center. We're in FQHC in Central Texas, McLennan and Bell counties, the majority of our 14 clinical sites falling within the city limits of Waco, which is the seat of McLennan County. Last year, we cared for just over 58,000 unduplicated patients, 37% of whom were completely uninsured. 80% of all our patients reporting income fall below federal poverty level. And recently, I saw a young uninsured woman in clinic who came to see us for symptoms she attributed to a sexually transmitted infection. And for the sake of the conversation, we'll give her the name Michelle. Because of COVID-19 related concerns and social instability, Michelle had not been seen by her primary care team in around 11 months, resulting in loss of control of her type 2 diabetes, and she had begun to have reemergence of symptoms from her major depressive disorder. She was out of medications for both of her chronic conditions, and Michelle demonstrated both a low fund of knowledge pertaining to her chronic conditions and overall low health literacy. Michelle was not interested in becoming pregnant and was not at the time of the visit on any contraception. So the question then is, how would implementation of these actions supporting the objective of access pertain to Michelle, and specifically in Central Texas, the tens of thousands of patients facing complex psychological, social, and biomedical challenges every single day? Well, quickly, in Michelle's case, empanelment means her team knows her. And she knows and trusts her team. As we in Waco grow more proactive in our care of individuals with chronic conditions, it also means that Michelle is on both the team's uncontrolled diabetes registry and the mental health registry, triggering regular contact by members of both her core and her extended primary care team. And with permanent implementation of COVID-era rule revisions, this contact through telehealth outreach and care will be financially supported in a way that makes this sustainable, which, as the one who's trying to budget for all of this, is really important to me. Additional members of our extended team include an eligibility manager who will help Michelle apply for public benefits such as Medicaid, and a women's health navigator who can further explore Michelle's reproductive plans and her beliefs around contraception and her values and goals. Because a patient majority board governing our center sets the nominal fee for an office visit, Michelle paid only $10 for her visit. And had she been unable to pay as an FQHC, she would have received the exact same care that she received from her team regardless. And because of our existing partnerships within the community, if Michelle does indeed get pregnant, she would have immediate access to home nurse visits through a collaborative nurse-family partnership. If she experiences domestic violence or tenant or housing issues or immigration issues, our medical legal partnership would provide attorney access for Michelle for any health harming legal needs. If her dietary habits center on high calorie, metabolically toxic foods, she can receive farm fresh produce at no cost through our prescription produce collaboration with a local farm. So you can see that each of these 5 actions support the access objective independently and move that proverbial needle in the right direction. And specifically, congressional appropriations supporting sustained investment in the creation of new health centers, target the underserved, and have unique relevance in our community and in surrounding counties that are underserved. Bob, I think I'm going to turn it to you.
Jackson, you make me jealous and want to work in an FQHC again.
Come on ahead. We've got room in Waco.
So what Dr. Griggs has just described in a visit to the Heart of Texas Community Health Center is exemplary of the kind of access that we're talking about. So we're not just talking about a place to go for care, but a place to go for care that is enabled to do and whatever patients need, or at least be able to redirect them to resources to get their care complete, and to be able to reach into community, to be a partner in community for solving patients' problems, and actually becoming an agent of community health action. So the committee had, as Dr. Hudson laid out, 5 objectives, and 2 others that I want to speak to because I think they're so critical to access are about payment and about implementation and accountability. The committee's recommendations about payment focus on the need to create new payment modalities and to evaluate them not just on their ability to deliver short-term cost savings, as many demonstration models have had as a requirement, but really how do they enable the delivery of high quality primary care? That should be the fundamental assessment of new models of payment. The second action that we recommended is that we move away from fee-for-service and towards hybrid reimbursement models where we have some fee-for-service, particularly around things that need to happen, need to be delivered, like vaccines, but most of it be put into per member per month or risk-based payment models that really create the flexibility that Dr. Griggs was talking about in Heart of Texas, the ability to use resources based on the needs of the community. But that those payment streams, because so many primary care clinicians now are employed, we need to make sure that the resources intended for primary care actually reach primary care. And that's part of our second action as well. Our third and fourth action under the payment objective really focus on increasing the overall portion of healthcare spending that goes to primary care. I think Shauna mentioned up front, but we only put about 5.5% of total healthcare spend into primary care, which provides over a third of all visits, more than half of all visits in the outpatient setting. That's decreased over the last 2 decades, and we're relatively starving this sector of our healthcare system that is foundational to patients and to access. And so we've called on CMS, we've called on states to really continue what many states have already started in putting a threshold amount of total healthcare spend into primary care. And in our case, we recommend that it be increased by at least 50%. And then it be spread across payers so that because a practice can't transform, can't change if only one of its many payers take that step. On the implementation side, one of our recommendations or actions is the formation of a Secretary's Council on Primary Care. Before the pandemic, if you look at our epidemic national strategy plans, they did not feature primary care as a component. And that was played out across this pandemic. Primary care was not part of the strategy, was not part of the vaccine rollout, really had no resources dedicated to it throughout the pandemic because there's no federal champion for primary care. Now, where you see some bright spots are in HRSA, which has oversight of federally qualified health centers and other health centers, and became an important part of the vaccine rollout. Health centers take care of about 1 in 10 people in the United States, but we need a strategy that reaches all of primary care to reach the rest of the folks in our country. And we think a Secretary's Council that can coordinate across all of the health agencies in planning and executing health policy for primary care, for looking at funding sufficiency, for monitoring workforce sufficiency, coordinating access and the adequacy of the federal government's investments in primary care really needs to become a focus within HHS. And in addition to a Secretary's Council, that there be an advisory committee, a primary care advisory committee made up of stakeholders who help that council establish its priorities and assess accountability over time. So those are the two kind of objectives that I wanted to unpack a little bit because they are so important to access. And thank you for the time.
Thank you, Bob. And I think it's these weekly webinars where we do a deep dive into one of the 5 major recommendations are very valuable. But I think what Bob shows us is that they're all connected, that you can't do access to care without also thinking about payment and the workforce and technology. And so we really encourage listeners to this webinar to take advantage of the coming webinars and the ones that have already been, the one that's already been recorded. I'm delighted to see that we already have some questions coming in from our audience, and I wanted to remind you as you listen to the next part of this webinar and our esteemed panelists that you use the Q&A function on the Zoom application to type in your questions, and we will get to as many as we possibly can. So now I want to move to the next phase of the webinar to hear from the panelists that we have with us today, representing different aspects of primary care that we felt aligned with this recommendation around access. And so I think the overarching theme of this report, as was previously said, is that primary care is a common good, that it is something that all should have access. But that doesn't happen with a snap of the fingers. There are a lot of things that have to be done on multiple levels to improve access in the United States. So just as we heard from Jackson about his on-the-ground experience with federally qualified health centers, my first question is for Seiji, and it is about our community health center program being expanded to improve equity and access. So Seiji, you are someone working in a large FQHC, serving a large population in DC. So what are the barriers that you see on the ground around access and the population that you face every day? And how can you work what are the things that you're doing to improve access?
Great. Thank you so much for that question. And I think like Jackson, we see probably a similar population, but, we are in an urban, area in the Washington, D.C. metropolitan area. Over 80% of our patients are immigrants from Latin America and Africa. And that context is, I think, important in terms of, when we discuss access. Barriers to access are, like everybody on this call knows, are many of the social determinants of health, including health insurance, time off from work, childcare, transportation, language barriers are all issues that, we deal with. And access is also about being available at the right time and the right place. And I think that, the pandemic has taught us what that actually means and what we are able to do. So, for example, I just had a televideo visit with a patient who is at work. She called me from a storage closet at work, and she works as a housekeeping staff. And I refilled her diabetes medicine and coached her on her diet. I also ordered blood tests and urine tests for when she can actually get off from work and she can come to the clinic just for that, so she doesn't have to waste time. I also referred her to see an ophthalmologist for diabetes. And I'll do a foot check in a few months when she actually can get off work and spend time in the clinic. And this was, a telephone call, a video call on her phone in a closet, and it took 13 minutes to do all this, right? And but this is actually the best case scenario. And she also had insurance. For some of our patients, video visits aren't possible because they can't afford the data, on their phones, or maybe they don't have reception where they are. I had a patient who came into the clinic a few months ago, so that she came to the clinic to use the clinic phone, and in order to call her doctor who is working from home. Right. She couldn't afford her phone anymore because she was unemployed and the pandemic was taking a toll on her family. So she came to the clinic to use our phone to call her doctor, one of our staff, who is working from home. Right. Just think about that, and so I don't think we think enough about, what it means, to provide the care for some of our patients. And technology is going to become more and more an important part of our access. Whether patients are accessing their laboratories through their patient portals or talking to their doctors and nurses and whatnot, and I think that the challenge for us as an FQHC, community health centers, is that we are providing care to anyone regardless of their ability to pay, as Jackson mentioned. last year we provided $8 million in uncompensated care, $8 million, right? And that's not trivial, right? We have to, like Jackson, we have a care team where, the payment, we're reimbursed for a provider, a nurse practitioner, physician, or a physician assistant to see a patient, yet, our social workers or health educators or, nutritionists, medical legal partnership needs funding from somewhere else, right? And so we need to be able to get reimbursed and support the comprehensive services, let alone the community, primary care is a community good. What about Wi-Fi and access to data? This may become a public utility that we need to ensure everybody to get. So those are some of the challenges that we get in addition to all the usual social determinant suspects.
Those are excellent points, Seiji. And I think there are two things that you said that really hit home for me. One is that technology, as we have seen with COVID, is an essential infrastructure for primary health care going forward. And second, the fact that it's not sufficient to just reimburse physicians, PAs, and nurse practitioners. There are other members of the care team providing valuable resources to our patients that we need to have models of reimbursement that work. And then the third thing is you really started your story, and also Jackson started his story about describing a patient and getting to know the patient and their individual needs. And as the committee did its work, one of the most exciting meetings that we had was a day that we listened to patients, and patient advocacy groups talk to us about what was important. And Barbara Leach just said had phenomenal messages to us. And so when we were planning this webinar, we were so excited to bring Barbara back to talk to a national audience about some of the things that she presented in May of 2020. You so informed our committee. And so could you share with this larger community, Barbara, what patients and families that you advocate for are saying about access to primary care?
Sure. Thanks for having me back. I'm excited about what's going on and what's in this report. And I'm really excited too about what's going on, I hope, across the country, I'm sure because of COVID. And here in North Carolina, we really are looking at access. COVID has caused all of us to take a look at how we serve individuals and families. For us, my organization works with families who have children with special needs, defined broadly. That's everything from intellectual and developmental disabilities and delays to behavioral health, mental health challenges, and complex medical conditions. So these are the high-end families who really rely on being able to access services and resources they need to have good outcomes for their children and for their families, because so goes one, so goes all. And families really provide the context for all children to thrive and grow. And that's whether you have a typically developing child or anyone else. And so what we have seen is, and we actually did the huge survey of over 200 families across North Carolina to ask them about access. And so they continue to be challenged with being able to access primary care. And, North Carolina is very rural across most of the state. And so in some places, there may be only one primary care practice that serves families over multiple counties. So many families talked about the challenges related to insurance. So either not having insurance or not having adequate insurance to be for being able to access primary care. Families also talked about not having enough local providers. Transportation is a huge issue. And, even if you have a primary care doc, if you don't have good transportation, you can't get there. And that's a huge source of anxiety for families. Language barriers is another issue. We have a large Latino community in North Carolina. And then we have many practices, primary care practices, without a bilingual doc or bilingual staff. And so for our Latinx community, often they're accessing primary care in a language that's not their native language. And we have children with complex needs and not being able, that just adds to their not being able to understand what's going on for their children. And throughout the report that we did when we surveyed families, access and care coordination are tightly linked. If you can access a primary care provider who gives you a referral to a resource, but you can't access that resource because you don't know how to, and there's no one to help you navigate the complexity of care that you need, then, that's a huge issue. People want to be served in their communities, and yet most of us, including primary care providers, are often unaware of what resources exist in the communities that serve families and that primary care providers serve. So that too creates a barrier for access to the kind of comprehensive, complex care that we're talking about. This speaks to our need to partner more, to really be able to go beyond just treating what's happening in the moment. There's so much about access for families. That means that you have to look at the whole family care, what's going on with that family. When we think about the families who have complex needs, who may be working low-wage jobs and paid by the hour, that time that they can access care, like CJ was saying about someone was in the closet at their job trying to talk to him. Not everyone even has that option, or needing to go somewhere else to be able to access care is a big issue. So,
Barbara, the stories that you have to tell just are so profound and really influence the committee and our deliberations. And it really points out, you advocate for one of the most vulnerable sectors of patients in our country. And these challenges are real. And if we can't meet the needs of our most vulnerable, how can we ever meet the needs of our entire population? Mm-hmm. North Carolina is very rural. I'm a North Carolinian, I know that. And some of the issues that you describe deal with rural communities. And so Alan Morgan is with us today, and he lives and breathes rurality and the erosion of the rural workforce and the loss of rural hospitals. And so Alan, if you had a chance to make a recommendation to the Secretary's Council of Primary Care for Rural Health, what would be your major priorities?
Thanks, Linda. Yeah, I definitely will have some recommendations when that time arrives. I can assure you of that. Thanks for bringing up the component of rural hospital closures. Last year, in the middle of a global pandemic, we saw more rural hospitals close nationally than at any time in the last 2 decades. That's just hard to believe. So in particular, I really appreciated the focus within the committee's recommendations on the expansion of community health centers, rural health clinics, Indian health service as well too, to try to fill that gap of basic primary care. In talking with reporters over the last year about hospitals as they face the pandemic, I just had to reiterate to them what rural hospitals do: primary care, general surgery. That's what they're designed to do. They were never designed to address a global pandemic, just not their scope. So I'm exceedingly pleased that one of the recommendations was the creation of this council within HHS. I see the greatest need there being the focal point within the administration, which currently doesn't exist. A body within HHS that can collaborate between CMS and HRSA and the other respective agencies, sorely needed. So directly to your question, there's 2 recommendations. Number 1, take the recommendation of this report and those that they have regulatory authority implement immediately. That's an easy lift. The second one, though, I think is a cautionary tale for all of us as we move forward. And that is, I would recommend that they meet immediately with the National Advisory Committee on Rural Health and Human Services. Chances are good, a lot of people on this call did not know that there's a National Advisory Committee on Rural Health, which charge is solely to advise the Secretary of HHS on how to ensure access to care in rural communities. I pulled up the last 10-year recommendations from the committee and saw they were perfectly aligned with the recommendations of this report body as well, too. We are in perfect sync here. The cautionary tale is this, and Bob addressed this at the beginning, the real push on this has to be the change in the reimbursement mechanisms and the redesign of our health system. That's going to take Congress. But nonetheless, there are important regulatory changes, especially in when we're talking about loan forgiveness programs, recruitment and retention of primary care in a rural underserved setting. So that's going to be the focus of my questions, Linda.
Well, you know, next week our webinar is focused on that workforce and getting the workforce into rural communities. So I hope you'll be with us next week to talk about that. How do you think, and Barbara, you may want to join in on this question also, if you had to give us a report card on how well we're doing in primary care for children in rural communities, where would you say we are?
Well, I may start, and then I'll turn over to Barbara because she has a view on the front line of this as well, too. So often when we talk about rural health, we're talking about an older, sicker, poorer population in these rural communities. And so just by the necessity of that, we tend to talk about a lot of senior care. And I find in the discussions, concerns about children are left behind. I would argue that that also comes into practice as well, too. And I think that's really behind the push of changing from a fee-for-service system of payment to redesigning where we're talking a public health community-focused approach. I think once we start moving to these new models of care, such as global payments, that allows both the community health centers to collaborate with the rural health clinics and the hospitals to do preventative care and to really address the public health component of the children's within our communities. And with that, I'll tee it up nicely for Barbara.
Thanks, Alan. I think that when you think about primary care for children, that if you think in terms of what does a whole child need to grow and to thrive, then you have to take all the things in consideration that include social determinants of health. health education for parents. You have to think about parent well-being, because it is that whole environment that creates the possibility for all children to do well. If you overlay on that the stress of having a child with a special healthcare need or complex need, where the types of services, resources, and treatments that they need, thrust that family into a healthcare system that they often don't understand, don't know how to access on their own, are often given referrals that fall short for one reason or another. Parents given a phone number, but yet nobody ever answers the phone, or they're given a name, but that person's not there anymore. So I think that it does require in primary care, I'd say for children, but I would say for all people, is that there has to be a way to more strongly align and connect to the resources that individuals and families actually need. So we have to get away from handing someone a piece of paper or phone number and saying, so-and-so will call you, or you call this number, because we know that that doesn't actually happen. And that doesn't happen for a number of reasons. Some of those are about families not feeling confident enough to make those calls. Some of it is about what happens on the other end of that call. And so I think we have to look more comprehensively about how we support individuals and families in general at the primary care level, if we want to get away from putting Band-Aids on and treating acute conditions and start looking more broadly at prevention and about creating, healthy situations in which people live in their communities.
Barbara, you bring a good point that the committee deliberated on, is that our primary care infrastructure is overburdened today.
Mm-hmm.
We cannot do it alone. Alan, you mentioned working with public health. Seiji, tell us about in DC, in a large metropolitan area, how you work with other community resources, including the public health infrastructure, other partners who help you develop this comprehensive model of primary care. If we can, it can't be on the shoulders of just the primary care provider. And so how do you develop these more comprehensive community engaged models, including our public health infrastructure?
Well, thanks for that question. And partnership is always challenging and it's very difficult. Even within healthcare, having a partnership with other FQHCs, other hospitals, specialists, are challenging enough to make sure that continuity of care is provided. But as we discussed, sort of some of the access challenges, we really need to think about some of the social services and other community partners. And at Mary Center, we partner with probably over 100 different community-based organizations. Some of these are very simple referral type arrangements where we just send patients to them, and some of them are much more integrated, like, Jackson mentioned medical legal partnership. We have a program where, it's much more tightly, partnered. And then we have partners that we actually even share board of directors and leadership within Mary Center. And one such example is our BRIA public charter school. And so BRIA is a public charter school sanctioned by DC Public Schools and funded by them. We provide early childhood development programs and education, as well as adult education doing GED programs, computer literacy. Like digital literacy, as I mentioned, will become a important piece of healthcare access. But think about banking, think about job applications, think about all sorts of stuff you do on your phone and on the computer we take for granted. A lot of our communities don't have that. So Berea Public Charter School does that. And they have this unique model of doing dual generation, two generation, educational programs where we enroll kids and parents simultaneously to make sure that, we are supporting the entire family. And we are co-located at 3 different clinical sites. So we have the school and the clinic co-located. 90% of their students are actually use Mary Center as their primary care. And when Mary Center patients need educational services, they go to Berea. And so, this is, I think, and our board of directors, we have independent board of directors, but the boards actually talk to each other and they attend each other's board meetings so that we are really aligned. And one of the cool things about Berea is that they have a medical assistant training program. Mm-hmm. And our clinic is actually their clinical training site. And so, they train the medical assistants and we help train them. They know our system and many of their graduates come work for us. I think it's a win for the students, for Berea, and for Mary Center. And I think it's one of the best practices. So yeah, community partnerships are so important. We can't do it without our partners. But, there are different levels of partnerships that we can do. And this is one of the best practices, I think.
That's one of the issues when you have an outstanding model like Mary Center. If someone were to listen to you, they would be like, well, then what's the problem? This sounds like a great model. But as Alan and Barbara can tell you, they're not in every community, in every environment. And it's important that we illustrate models that work, but at the same time, we have to realize that there's not enough of these models in the United States. And how do we give HRSA the tools that they need to expand this network, to expand these models? You mentioned about community engagement, and one of the recommendations of the report is the engagement of people from the community on primary care practice boards. Now, Seiji, I know you have it. It's very obvious in your discussion. Barbara and Alan, can you share with our audience what you are seeing out in your communities that you serve?
Yeah, I want to highlight that because I think it's a really, really important point. And I hear this from our membership all the time. They're like, we're in a small town. Of course we have community people on our board. What would you think that we would have on the board? But I think it's a real, and I have to ask them to pause when they say that and say, let's talk about that. Yes, you have the banker, you have the business leader on your board, but do you have patients that you're serving in your facility? And there's a huge difference in that to make sure that it's community directed and that you're actually meeting really the goals of this report that you pulled together on that, and that is improving the overall health of the community and the status. So I always have to say that because in a rural community, of course, whoever you have on your hospital board, your clinic board, they're going to be community members. We're really talking about who are those members of the community and are they reflective of the different components of your community? And I think that's really important. Barbara, I'd turn over to you.
Yeah. So I want to talk about 2 things. One, what Alan said about you need people who reflect the people that you serve on your boards and on your community committees. But I want to also start with saying that I think that we need to extend who we think of as community partners, because there are people in the community doing great work to support the individuals, the families, the patients that you see in your primary care practices, that we don't often make as strong a connection to as we might need to think of. Those would be like our food banks, especially now with so much food insecurity, that we connect more strongly with our faith communities because honestly, families who have complex needs are very often families of faith because that's exactly how you get through it. Those faith organizations are providing really basic needs for some families. They have food banks, they have clothing banks. And I want to stress the importance of the social and emotional well-being of the people that you see in practice. It is hard to be someone struggling with basic needs and having a child with complexities, or struggling with your own physical health and mental health and your child's health and being job insecure, food insecure. So I would like for us to step back and think some about what are the social emotional needs of caregivers who are doing hard caregiving, heavy lifting every day, and while dealing with their own mental health and their own family structures. And so I think that's something we need to think about when we're thinking about primary care, because it impacts our ability to do what needs to happen for, for our own well-being, our child's well-being, taking medications and all of that is hard to do if your mind is in a fog and you're anxiety driven. So I think to think about social emotional well-being is something that needs to happen. And I just want to say this because this is so really important to me, is that we need to think about hiring families as family advisors in primary care practices, as family navigators who have been there, done that themselves, and really understand the ins and outs of systems. And because they are my peers, they have credibility that sometimes providers don't have. And I can learn from them in a way that makes me feel more confident because I'm learning from someone who really does understand what it's like to be me, because they've started that journey and are now in a place where they can give back to others. So I would like for us to think more broadly about who our partners need to be flexible in thinking about those partners and thinking about how they can help us do the work that needs to happen in primary care, because we're talking about, we're asking practitioners to ask really complicated questions that they may not have the answers to, but community might. And I think that it's really important to give that warm handoff in a way, or connect them with peers in a way that can help them feel more competent and feel more comfortable doing that lift. And as we say in children's mental health and in working with families with all kinds of abilities, nothing about us without us. And who knows more about how to best spend money than the people you're spending the money on. And over the course of my 35 years of doing this, I have seen so many times that agencies and systems spent money on things that families already knew that they weren't going to do. But we were so committed to our models and our theories that, we didn't do anything about it. So I'll stop.
So Barbara, the committee spent a great amount of time talking about models of care delivery, this extended care team that was not part of the 1996 primary care report, and the critical role of community health workers or family health workers that is emerging, the knowledge and expertise of these individuals. And of course, the challenges of paying these individuals and families for the expertise they bring to the team. And so, it was a huge emphasis of the committee, and we do have projects throughout the United States where you see this model of care delivery, but it's not uniform.
So we pay for what we value in this country. And if we're going to say to families, come share your expertise with us, and everyone at the table who has expertise is being paid for their expertise, except for the family who took off from their hourly job to be at the meeting, that ought not to be okay. And it says, we're telling you you have expertise, and we're telling you that we value it. However, we're not paying for it, so which means we don't value it that much. And we as families aren't seeing it reflected in the policy, programming, and practice that comes out of all that time that was spent. So I think that's how you model it. I think it's necessary that you do it.
Thank you. Thank you for that. I've got a tough question. I'm going to direct it to Seiji, but all of our panelists can pipe in on this one. And it's the concept of empanelment. And it is one of our major recommendations of the report that primary care is a common good, and everyone should be asked where their source of primary care is and if they utilize it. On the ground, rolling it out, what are the challenges with the concept of empanelment? Any thoughts about that?
Yeah, good question. And I love the concept behind empanelment. I wholeheartedly support empaneling patients to care teams and having a health home for everybody, and it's really about improving continuity, right? And continuity improves quality and then outcomes. You don't duplicate efforts, you understand what the patient's needs are, and relationships are such crucial components of, care delivery in any setting. And trust, like, Barbara talked about, trust is so important in how patients, view care, receive care, and follow through with care. So, empanelment is so important. But on the ground, empanelment is very challenging. It is super challenging. One of the biggest operational challenges, especially for urban health centers like ours, is that patients go to multiple clinics and multiple providers. They go to different ERs and different hospitals and different specialists in different systems. And trying to sort of bring this all together, sometimes it's really hard. And this could be because, there's not an appointment availability, when they need it, or they happen to be in a neighborhood where they're working and they needed quick access. Maybe one pharmacy has a pharmacy and another one doesn't. And there's so many reasons why patients go to different places. And then there are other issues, life issues. Many of our immigrant patients are migratory. And, they may move around the region, or they may move around the country, or even across borders. We have many families that go back and forth from, Latin America and the United States. We have many families who spend 6 months in Ethiopia and then 6 months in Washington, D.C. This is common. How do you maintain, continuity of care in this kind of system? I'm hopeful that actually telehealth and a move away from fee-for-service will enable us to better connect. And, as, Barbara talked about, who's the right person to connect with the patients. And I think that, the primary care physician or nurse practitioner or PA may not be that person, perhaps a health educator or a care navigator, perhaps, a social service person, depending on who that, the main needs of the patient is. It could be dental, right? Or behavioral health. In our case, it could even be a teacher, who is the primary contact. And so I think that we need to kind of find, a connection point, no matter what, sort of thinking about the whole person and the whole needs, and then empaneling to not just that, few people who we consider clinicians, but that broader primary care team.
We might want to think about the term empanelment in itself. It sounds like something we're trying to do to people versus a service that everyone should have the right to. But I will leave that for others wiser than I in terms of.
But that is a really key point, right? We want patients to choose us. We want to create a health home where patients want to come to us and want to stay with us. And I think that, being able to provide all the comprehensive services that, a patient needs is an important piece of, keeping patients, continuity and in the family and the fold of, and caring for the entire person.
So our challenge is how do we have enough of, quote, us for people to, through whatever mechanism we do to put out the word, they seek this valuable care provision that everyone should be entitled to. So, wonderful dialogue. In our last 15 minutes, I want to turn it over to Mark Masner, who's been looking at our audience questions, and to be able to have the panel and other members of the committee that's here to respond to our audience questions. So, Mark, can I turn it over to you?
Sure. So we talked a bit about federal actions with the Secretary's Council and also kind of health system actions. We did have a question about states. What are some things that states can do to better improve access? And are there states that have been particularly effective at improving access to high quality primary care that could be looked at as exemplars? And also, what do they do and how do they do it?
We heard so many great exemplars in the committee. I'm wondering, Alan, if you and Bob could do some comparison of things that have worked in one type of state versus another.
Well, I might start and let Bob follow up on that. Sure. I think at a state level, when states work on the recruitment and retention component of primary care, in particular, coordinating loan forgiveness programs, establishing grow your own programs, which I think are so incredibly important in primary care. And this was touched upon in the report as well, too, about so often that our primary care clinicians do not reflect the communities they're serving. And that is because how we do it. We get the best and the brightest from upper income families in urban areas. We train them in urban areas and we're dumbfounded that they don't want to practice in rural America. A better approach would be to grow your own, utilizing the state to establish loan forgiveness programs to allow them to come back, serve the community where they want to be with their family. That's just one. I think when we're talking, we breached on the topic of telehealth, establishing state compacts to allow the provision of primary care services across state lines. Tremendously valuable. Boy, in the upper Midwest, what a huge godsend that has been for primary care and even direct primary care as well in that regard. So those are the two that come to mind right now. And I'll turn it over to Bob to mention some that I might have forgot off the top of my head.
Oh, I thought that was excellent, Alan. And I think more of that will come up next week in our session on workforce, particularly around training.
Mm-hmm. From my own experience, I've done more than 2 decades of immigrant care delivery, particularly in agricultural sectors. And when I look at the migrant clinician, the migrant clinics that serve, they're primarily in rural communities, and a lot of rural communities have wonderful facilities with the core and an extended healthcare team. Those clinics could not have been possible without people from the community in the agricultural sector caring about this workforce and caring about all members of their families. And so they're phenomenal models of caring for very vulnerable workers that we need in our country, and are great models of primary care. So I don't think we should overlook stakeholders in the local community who recognize people need access to care to be healthy and give back to their communities. Mark, another question?
Sure. And this one also, to go back to what Linda said, how all the objectives kind of are interrelated. This one is about workforce, but how it relates to access. So would expanding access to primary care require that more physicians be trained or other clinicians? And what would be the plan to staff new primary care or new health centers?
Great question. And Alan's raising his hand on that one. I'd love to take that one. Yeah. So at least over the past 30 years, all we've been talking about is a maldistribution of clinicians. And I think that still is the case, certainly in underserved communities and underserved populations. And again, I think taking a new approach, taking a new approach on how we grow our own and how we make sure that the clinicians reflect our community, number one. Number two, changing from the fee-for-service to this community-based approach that is the core of these recommendations in this report, goes a long ways towards that. And three, the telehealth component. When I got the report, the first thing I did was go straight to chapter 7. I wanted to see how you guys had tackled the telehealth issue. And I got there, I'm like, well, that kind of misses the mark. And when you see this report, you see that telehealth is ingrained in the entire report. And when I got done with the whole report, I said, yes, that captured where we are and where we were and where we're going perfectly. The report does it. It hits the mark. But we really have changed the dynamic. And I really do believe it's not the end-all solution, but as a tool, telehealth is going to help after this pandemic get us to where we need to be on getting that connection, that primary care connection that you've heard.
That's an excellent point. Shauna, any reflections from your standpoint in terms of preparing the workforce?
Trying to unmute here. Yeah, so, the other thing that I think was brought up in that question is really thinking about all of the different folks who are on the workforce in addition to the clinicians. And so that was one of the things that sort of I put in the chat in response to this question when it first came up, is really that we need to be thinking about all of the different groups, and really the task for us was in this reimagining in the current space where we are now socially. What do all the different groups do? What do all the different members of the team do? And then how do we integrate that more fully with the communities and with the community partners? So I really liked all the things that Alan was just saying about this, because it really sort of gets there. And I see Seiji has his hand up as well.
Yeah, I wanted to combine sort of the telehealth and sort of, thinking about the care team by giving an example of what we do at Mary Center. We have a program called the Facilitated Telehealth Program, where we actually send medical assistants to people's homes. They actually carry a bag or a huge box actually that has, lab equipment, electronic stethoscopes, vaccines and everything to the person's home, while I sit in my clinic with a video monitor, and my medical assistants are my hands, ears, and eyes, right? And although I can see and sort of guide the medical assistant and everything they do, they put the electronic stethoscopes on the heart and lungs, and again listen to their, and I can order labs and vaccines right there in the patient's home. But they also see what's going on in the home, and they can sort of talk to the patients and like look in the refrigerator. And, I was doing a video visit with a patient, an 80-year-old woman with end-stage renal disease. And I kept on seeing her on this couch, right? Every sort of few weeks that I met with her. And it turns out that when I sent my medical assistant there, it turns out that that couch is her entire sort of living space. She sleeps there, she sits there, she eats there. I had no idea, right? And so having sort of, and our medical assistants come from our community that we serve, actually. And so they know the neighborhoods and the families. And, you know, when we think about the core care team, I can't imagine functioning without our medical assistants. And so combining technology and people from the community is going to be such an important piece of how we provide access.
That's a great point. So what do you think, Mark, do you have another question or can I throw one in? Do you have one from the audience?
There's one more, but go ahead. Ask yours.
No, go ahead. I'll save my comments to the end.
All right. So we had a question about the trend of hospitals acquiring primary care practices to feed the larger system. How does this trend affect access and kind of jive with the report's overall recommendations?
I know all of our panelists have seen that, even our patient advocate who has seen their care providers changing names in their community. So anyone want to speak to that issue?
Yeah, let me jump in here, Linda. We have really rich relationships with two hospital systems in McLennan County, the Baylor Scott and White system and the Ascension and the Ascension system. It goes back to 1970 when we started a family medicine residency program, and we've really supplied the community's primary care clinicians over the past 52 years now. And so there's this rapport that was established through graduate medical education with the two hospital systems. But in that in the process, we became an FQHC in '99. We have developed, the hospitals have developed a respect for the FQHC, what the FQHC offers the community. You know, in healthcare systems, there's so much cost sharing that doesn't get accounted for. If we can do preventive medicine that prevents someone from an initial hospitalization, or secondary prevention, keeps someone from rehospitalization, or prevents an acute exacerbation of a chronic disease, you know, there's massive savings for the hospital for an underinsured patient. So we, by just, so I think waving that flag, signposting on a regular basis right now, there's a sense in which both hospital systems want to protect the FQHC, ensure its success in the community, because if we didn't exist, then the hospital systems would be responsible for the care for those who are uninsured. They wouldn't reap the benefits for the preventive work we're doing in primary care. That goes on, you know, every day of the week.
Bob, do you want to say?
I'll be brief because I want Barbara to talk about this too. But I think the fundamental problem is the role of primary care relative to the business model of the health system. In a fee-for-service model, the role of primary care is really to feed people to the health system so that their higher revenue-generating services have supply. And in that model, you know, primary care gets put on a hamster wheel of generating visits and making referrals, and it winds up reducing the scope and the capacity of primary care to solve problems. If we can move towards more of a perspective or population-based model, where the health system gets a pot of money for managing a population, well, empanelment becomes suddenly very important. And the role of primary care in solving those problems up front and reducing the cost to the health system become critically important. So I think the payment model will really help dictate how this pans out and how primary care gets used. And right now, the dominant model means that as health systems acquire primary care, it can be quite disruptive to relationships. It can be quite disruptive to teams. And it's generally not in primary care's favor.
So I have the unfortunate responsibility to watching the clock and telling you that our time is about out. But a good thing about this webinar today is that it is a huge overlap with our webinar next week. And I encourage particularly our panelists to join us again next week, because you cannot talk about these models of integrated care delivery, patient-centered care delivery, without thinking about who are the people that are going to deliver this care, whether they come from about engagement of the community, engagement of the schools, and medical assistants and help techs, phenomenal things that we can do, all the way to preparing more primary care physicians and advanced practice providers. So I really encourage you to join us next week. It's next Tuesday, the 6th of June at 11 a.m. Same place, same smiling faces. On board for next week, so please join us. Any closing comments, Mark?
No, just want to thank all the panelists and for all the participants for joining us today, and we will see you next week.
It was a fantastic session. Thank you so much. Bye-bye, everyone.
Bye-bye.